realizing that what we are doing is a component, and what we are is a partner within a very complicated ecosystem. We have the physicians, we have, as you said, the PACS vendors, the scanner vendors, the hospital administrators, the different hospitals, but also we have the medical device companies that have the device treatment for stroke. We have the pharma companies that have the drug treatments for stroke. And one thing we realized from the outset is that ultimately our value proposition is to increase the uptake of existing treatments in clinical practice. And working closely with all these partners in this ecosystem was a key way to further drive adoption and ensure that we are creating value for all the different stakeholders in this ecosystem.
Welcome, MedTech Gurus. Today, we're delighted to be joined by Michalis Papadakis, the visionary CEO and co-founder of Brainomix, an Oxford University spin-out that is redefining how AI and imaging come together to save lives. Michalis holds a BS in biochemistry from Imperial College London and a PhD in neurosciences from UCL School of Pharmacy. Prior to founding Brainomix, he served as scientific director of the preclinical stroke lab at the University of Oxford. Under his leadership, Brainomix has developed the Brainomix 360 Stroke, a world's first automated suite of AI-powered imaging biomarkers and software solutions deployed in 30-plus countries, backed by 56-plus clinical publications, and processing a patient scan every 3 minutes with results available within 1 minute. The company's stroke module alone has shown dramatic improvements in patient care. For example, one evaluation showed tripling of functional independent rates from 16% to 48% at one center. Today, Michalis will share with us the innovation behind Brainomix clinical impact, how they scaled globally, and the lessons medtech innovators can draw from their journey. Hey, Michalis, you ready to be our guru today?
Absolutely, and thank you for the invite.
Oh, we're excited to have you. So tell us something fun about yourself or your family so we can get to know you a little better.
Yeah, so, and again, thank you for this very kind introduction. So outside Brainomix, my other full-time job is raising my family and being with my family. And my wife originally she was actually born in Iran and she was raised in Sweden. And I come from Greece. So we have 2 children, a 4-year-old and a 10-year-old son. And therefore, there is a melting pot of cultures in the house and a melting pot of cuisines. So there's a lot of interesting dinner parties we're hosting.
Yeah, I'm going to come over for dinner someday. That sounds great.
Yes.
Yeah, so what are the kids into?
The kids, first of all, are catching up with all the languages they need to learn from their 2 parents, as well as going now through different phases in school and as well as being kids.
Yeah, that sounds like a very busy household. So you started your career in basic science and neuroscience and then moved into entrepreneurship with Brainomix. What motivated that transition and how did your scientific background shape the vision for the company? Can you provide us some insights there?
Yeah, of course. As you said, Tom, I started as a basic neuroscientist. So I did my PhD in molecular neurosciences, looking at the specific type of receptors we have in the brain that is related to stroke. But back then I was looking at how these kind of receptors are produced in the brain and the importance of how they are transported within neurons in relation also to disease. And then when I moved to Oxford, ultimately I became the scientific director of the preclinical stroke lab here at the university. And my research was focused in stroke. Mm-hmm. And whether firstly, I was looking on ways to protect the brain after the stroke, so looking into neuroprotection, and also at biomarkers for stroke. Can we detect stroke when it happens? And throughout, I would say, my career and throughout my life, my key driver was innovation and impact. And how do I use science and my scientific background to create something meaningful that transforms how patients are managed and how patients are treated. And I had the great opportunity when I was at the University of Oxford doing research, together with one of our other founders, Professor Alistair Buchan, who is a professor of stroke medicine here in Oxford, to spin out Brainomix with the intention of ensuring that patients that have stroke don't miss out from life-saving treatments. And the way we transitioned from the research I was doing to founding Brainomix is starting from this unmet need. Because we know in stroke, even now, up to 80% of patients that should be treated are missing out. And a key barrier and a key contributor for so many patients missing out is that because strokes happen in the community, they go into stroke centers where there is a lack of readily available expertise by the frontline clinicians to interpret the brain scans of those patients, which is a key driver of how patients are managed. So the seed and the birth of Brainomix was whether we could use AI to automate the analysis of those scans to give to all frontline clinicians globally the ability to use this kind of technology as a decision support tool to timely diagnose and ultimately treat more patients.
Mm-hmm. Yeah, that's really interesting, and we'll get into some of the nuts and bolts of Brainomix in a moment. But we often talk on MedTech Gurus about the need to really immerse yourself within the clinical world, right? So it sounds like you started out with almost an advantage. You were totally immersed in this from the beginning, right? And then could understand the unmet need.
Absolutely, and I think this is a key driver. One of my key learnings that many times, especially as academics, we are very much driven sometimes by the science and the technology rather than the unmet need. And we are trying even sometimes to retrofit what we are focusing on our research to an unmet need. And starting with the unmet need is a key way to ensure that whatever you are developing, there will be, first of all, some interest, some clinical adoption, and ultimately some clinical impact. And that is something I would say, coming back to your original questions about my scientific training and how this is contributing to what we're doing in Brainomix, is learning how to ensure that what you are developing is, first of all, clinically meaningful. And the background that I had, and as I mentioned, our other founders had, knowing how patients are impacted potentially by such solutions was a key factor to ensure that by developing such a technology, although obviously when you start, you are never absolutely sure about how this will impact and will be integrated in a clinical care setting, but we had, if you like, a good foundation and good evidence that there was an unmet need, and what we're working on from the outset would definitely have a good application.
Yeah, that's outstanding, and that's exactly kind of the blueprint of how to do this, right? And then I was doing my research, and if I've got this right, the Brainomix 360 stroke platform indicates that it can scan a patient every 3 minutes and get your results within 1 minute, which is extraordinary in my opinion. So I'm wondering if you can walk us through, how you and the team achieve that level of scale and speed, and what that underlying architecture of that innovation looks like. Can you take us through that?
Of course, it might be worth going through an overview of how the technology works to give you a bit more color on how we achieve that kind of scale and this kind of outcomes. So, as I mentioned before, strokes happen in the community. The patient would go in a primary stroke hospital. We call them spoke centers. At this stage, this is globally the current setting. The patient will have a head CT scan, and the frontline clinician has to interpret that CT scan to, first of all, diagnose if there is a stroke, and secondly, decide if the patient is a good candidate either for clot busting thrombolytic treatment, a drug treatment that we administer, and also whether the patient should be transferred to a comprehensive stroke unit, which is called the hub, where they can receive a very powerful treatment we have, which is called mechanical thrombectomy, with which treatment we mechanically open the artery that is blocked, that's causing the stroke. And imaging, as I said, is a key driver for all these decisions, and imaging, especially for non-specialists, is very challenging in the interpretation of imaging. And that is why many patients are either delayed treatment And many patients are even missing out from treatment completely. And that's exactly the unmet need we are addressing with the technology we have developed. So what the technology does is it integrates seamlessly within the current patient pathway. So the patient will have the scan, the scans will be produced. What the technology does and where the AI comes in is for us, once we are live within a hospital, automatically to get the scans when they are produced, our solution in real time to process the images. That's why we have such a fast turnover of processing. And all this happens with what we call a zero-click approach. So it's completely automated, completely integrated. So the physicians get automatically the process scans with our AI algorithms in their fingertips, literally, because we provide the results on a mobile app that the physicians can have even on the smartphones. We send them back to the imaging workstation, the PACS systems that they usually review images. So whether they are next to the patient, even outside the hospital, immediately they will first get alerted whether there is a patient that has a potential stroke. And what the algorithms do is they process all the different types of scan the patient will get, so that we can identify automatically if there is a large vessel in the brain blocked, causing the stroke. We can measure the location and the extent of damage at the time of imaging. We can also, in places that have access to what is called advanced imaging, CT perfusion, where we give a contrast to the patient and we can visualize the blood flow, we can measure again not only what is irreversibly damaged at the time of imaging, but also what is called tissue at risk, which is brain that is compromised, and if we do nothing, will also infarct and therefore will be irreversibly damaged. But if we treat the patient, we can salvage it. And all this information give literally a picture to the physician on what is the best course of action. First of all, in terms of diagnosis, if it is a stroke, to confirm and give them confidence that this is a patient that should be identified as a stroke patient, and importantly, whether the patient should be either be administered with thrombolytic treatment and whether they should need to be transferred to the comprehensive center to receive mechanical thrombectomy. Mm-hmm. The other aspect of our platform is it acts as a communication platform. So not only we deploy our solution in the primary stroke centers, in the spoke centers, but across stroke networks, because as I mentioned, patients are managed across stroke networks. And therefore, the physicians at the hub center, at the comprehensive center, will also be alerted that there is a patient that was scanned in the primary center. They will have access to the images of those patients and the post-processing with our algorithms. And we will enable through our platform the communication between the stroke teams if the patient needs to be transferred. And that's a key way we are also saving time and we are providing a fast turnaround.
Yeah, that's fantastic, and we'll peel into some of that information here in a little bit. But my initial reaction is this is going to be really helpful, especially for like some of the outlying and rural centers across the globe, really, right? Because if you're in a big urban center, time is everything when it comes to stroke, right? So if you're in a big urban center, you might be able to shorten that time frame. But I'm thinking rural. This is going to be a real useful tool.
You're absolutely right, Tom. And as we say, and you noted, time is brain. And anything that helps speeding up and collapsing in some cases this process adds fundamental value to the patient and fundamental value to the outcomes of the patient. So the way we are improving on that is, as I noted, based on the integration, that we ensure we don't add to the workflow of the physicians. Is absolutely seamlessly integrated. But also, which it's worth expanding on, is having a solution that physicians trust. And that's a key word, in my experience, for generating adoption, because ultimately physicians would make potentially life-saving decisions based on the output of our technology. And they need to feel that even if this is a decision support tool and ultimately it's up to them to make a decision, the way that we are augmenting their decision making is in a very reliable way.
Yeah, and you mentioned trust, right? Which actually leads into my next question for you, because trust is all about clinical validation, right? And if I've got this right, you've done more than 56 publications and global deployments, right? So help our gurus out there, because getting those types of studies is very difficult. So how did you and your team build this clinical evidence base, and what were some of the key findings that made a difference to help build that trust? Can you provide us some insight there?
Absolutely. And I would say, coming from Oxford, it is within our DNA to be driven by evidence-based medicine. And we have invested a lot, and for the very right reasons, on generating evidence and evidence of impact. Mm-hmm. Which, of course, when we started, we had to generate evidence that the performance of the solution is comparable to an expert, but more importantly, the utility of these solutions, because they are decision support tools, is measuring how they improve the performance of the physician. And we have shown at this level that we are improving the sensitivity and specificity, of course, of less experienced physicians, but even for experts, we have shown we are improving significantly their sensitivity and specificity. At the same time, the acid test, and that's something I think differentiates Brainomix from other companies in the space, is on the depth and breadth of clinical impact evidence. And one of our key milestones last month in December 25 was when we published our study in Lancet Digital Health, where we carried out what is the largest scale evaluation of not just the stroke AI, of any AI solution globally. And through that study, we demonstrated that we can double the number of patients that get selected for mechanical thrombectomy. We save time, almost an hour in decision making. We are improving outcomes. As you mentioned in your introduction, we have shown that we can treble from 16 to 48% the number of patients having almost full recovery after having a stroke, because we know the treatments work. And this was, importantly, a very comprehensive study, because first of all, it was a prospective evaluation. So this was across England. We included in the study almost 450,000 patients over 3 years. We deployed the solution in 26 centers here in the NHS in England, and we compared quite rigorously the impact of our technology when it's deployed clinically, both before and after. Also, we compared sites that were using our solution clinically versus sites that were not using it. And even within sites that were using our solution, we measured when physicians used our solution for their decision making and when they didn't. And throughout all these comparisons, there was a clear signal that we are significantly moving the needle on how many patients are selected for mechanical thrombectomy, also for thrombolysis, when hospitals, healthcare system, and physicians are using our solution. And it is this kind of evidence that has now enabled us to have a very significant adoption across Europe. We are the European market leading solution in stroke AI. Now we are making a significant effort to generate similar adoption in the US and replicate the evidence we have shown in Europe. We have more than 350 sites, hospitals globally using our solution. And importantly, more than 2 million patient scans have been used and processed with our algorithms in clinical care, impacting the decision-making of frontline clinicians.
Yeah, that's remarkable. And that kind of helps me out, because I want to focus for a minute on the business side of this, right? And many of our gurus out there have tried, spin outs or licensing from universities. And I'm just kind of curious, scaling from a university spin out, at Oxford to more than 30 countries, that's no small feat. What were some of the major hurdles you faced in going global? And help our gurus, how did you overcome a couple of those?
Yes, and I would definitely say, Tom, it has been a journey which hasn't been a straight line, being very, very upfront about it. And when we started, we were the first company globally to launch a stroke AI solution. And back then, I would say AI was not even a thing. So there wasn't so much expectation or knowledge even about the value AI can add, especially in this space, where, as I said, trust is a key factor, and skepticism was, at least when we started, the key reaction on having neuroradiologists and physicians questioning whether they do need a solution like ours to help them. So the first barrier was overcoming in these early stages that what we had was not only fit for purpose, but was actually in principle adding value to their day-to-day practice when they were reading and interpreting scans and when they were making important diagnosis and treatment decisions. And what we realized, and it goes back to the focus we have on evidence generation, that was, first of all, that physicians rely a lot on evidence. So going and investing on generating this evidence was a key learning to generate this trust and this adoption. But at the same time, a key learning was that beyond the evidence, the way physicians experience and interact with the technology is a key factor for adoption. And even how the user interface is and ensuring that it's very intuitive and very easy to use, it is again very important to get the kind of buy-in and the kind of adoption we were building back then. And what we realized as we started scaling is that once you generate the evidence, there is, based on our experience, an outcome where you see that healthcare systems become the buyer. Mm-hmm. So instead of going, when we started, from hospital to hospital, trying to convince the physicians and a specific site to use it within the stroke pathway, we see now that at this stage, adoption is at an enterprise scale. We can see that adoption is either at the regional level or even in some case at a national level. And we have won national competitions in places and countries and healthcare systems like Wales and Poland and Hungary, where all the stroke units have adopted our solution, which is when you see the maximization and the optimization of the impact we can deliver.
Yeah, that's really, I like that. And, it leads me to my next question, because getting to that enterprise level, right, especially from a startup perspective, you're talking about you got to get adoption in clinical workflows and hospital systems. That's really challenging, and it sounds like you're on your pathway, to achieving that for sure. So back us up a step. What tactics did you use to drive that kind of clinical acceptance and integrate with some of the systems out there, like the PACS systems and the EMR? Can you help us understand how that got to that, demonstrating that ROI for the hospitals?
Of course. Firstly, it has to do with how we designed the solution and the technology. We ensured that our technology is essentially agnostic to the specific PACS a hospital might be using, the specific scanner, CT scanner they might be using, whether it's Siemens, GE, or any kind of vendor, and that we have the ability to integrate to whatever infrastructure the hospital has without changing what they are doing. Sometimes we help hospitals optimize the stroke protocols, but ultimately we are trying to ensure that, again, we are seamlessly integrating. So the way the solution was designed was a key factor that enabled that seamless integration. The other factor is you learn as you build and you deploy. And the more we installed, the more we had, as I mentioned, healthcare system adopting our solution. We had to learn what is the best way to optimize and ensuring, in terms of becoming vendor agnostic, that we deploy in a way that is comfortable for the hospital. So in our case, we can deploy either on premise, where we install a server within the hospital infrastructure. We can also deploy on the cloud. And as I mentioned, we connect hospitals within a stroke network. So again, we have an infrastructure and a platform that enables the integration and the communication through our platform between different sites.
Yeah, that's fantastic, and I can see how that connectivity, right? Coming back to my rural center, example, right? Because if you can connect with the major university center, but with one of the outlying hospitals, I'm thinking that you can almost treat the patient on site at the rural hospital, but have the expertise of the university center supporting that. Am I heading down the right path with that?
You are correct, and by connecting the spoke and the hub centers, which is what you refer to, the university centers and the primary centers, is very valuable. First of all, because more than 80% of patients that have a stroke first go to a primary center. So that's where the unmet need is. Secondly, the teams in the comprehensive center, in addition to potentially helping, and especially in the US, you have telestroke networks where there is an established structure and infrastructure where you have centralized teams of neurologists and neuroradiologists helping these rural centers. When they are using our platform, again, they see value. And that's, again, how we can help definitely the rural centers, but even for patients that are admitted directly to a comprehensive center, even there we are showing that we can help the experts augment their own performance and further improve the management of the patients.
Yeah, that's fantastic, and I'm going to ask you a question that's a little tongue in cheek here, but you initially discussed building the innovation, the engineering behind it, and staying focused. But when you're doing some of this and you get in the operational end of it, right? I'm thinking the engineers are looking at all these shiny objects, right? So I'm wondering maybe how you and your team kind of balance the two, right? The algorithm and then the operational workflow. So to build that technology and build the business, can you maybe give us some insight on how you stayed so focused to get that kind of implementation?
I think this goes back to the principle we started our discussion, Tom, on starting with the unmet need. And that's why having this as our anchor, the way even we operate is very relevant, that we have a product team, we have a translational medicine team, we have an engineering team, an R&D team that are all working very closely together. So we have, first of all, in-house people that are radiologists, frontline clinicians themselves, so they can provide direct feedback in terms of the product roadmap and the product development. We have customer success teams that are on the ground in different countries, understanding the nuances of different healthcare systems and in different countries and even within different networks, and have them all working very closely together, communicating from the ground both the patient journey, the physician experience and expectation, and then the intricacies in terms of technical integration. And I think an important component that is worth mentioning to the point of how does this scale technically and clinically is realizing that what we are doing is a component, and what we are is a partner within a very complicated ecosystem. We have the physicians, we have, as you said, the PACS vendors, the scanner vendors, the hospital administrators, the different hospitals, but also we have the medical device companies that have the device treatment for stroke. We have the pharma companies that have the drug treatments for stroke. And one thing we realized from the outset is that ultimately our value proposition is to increase the uptake of existing treatments in clinical practice. And working closely with all these partners in this ecosystem was a key way to further drive adoption and ensure that we are creating value for all the different stakeholders in this ecosystem.
Yeah, that's fascinating, right, Michalis, because it's, funding and partnerships, I mean, they're really difficult and they certainly matter. And, Brainomix has raised significant investment, if I've, researched this correctly. As mentioned, you've partnered with some major health systems and industry players out there. So what kind of strategies did you and your team use to develop these partnerships? Because I'm thinking that's not really easy.
Definitely, again, it's not a straight line, but is, as I mentioned just now, essential. And the way we approach these partnerships, it went back to the principle of having strategic alignment, both on the vision and the purpose of why we are partnering and what we are doing as Brainomix. And for example, as you noted, we have very deep partnerships with pharma companies, medical device companies. We have raised significant investment. One of our investors is the venture fund of Boehringer Ingelheim, the German pharma company that globally manufactures the only drug treatment we have for stroke. We have a commercial partnership with Medtronic in Western Europe, who have the device treatments, the thrombectomy device treatments in stroke. So where it is all linked, all the themes we are discussing, is a key driver of all these partnerships is, again, going back to evidence. So generating evidence that we are creating value for these partners is a key driver to demonstrate the strategic alignment and have a partnership where there is a clear pathway of how we complement the strengths and the focus each company and its partner has to ensure that the added value is more than the sum of its parts.
Yeah, that's really helpful. And I'm wondering if you could now, share for our gurus out there, right? Because you and your team have done a phenomenal job. As you mentioned, it's not been a straight line. It's taken a lot of dedication. What one piece of advice would you give to medtech founders out there who are working to scale a solution like an AI solution in critical care or imaging? What would you tell them?
I would probably emphasize some of the highlights I mentioned throughout our discussion, Tom. So the first one is always ensure that you have started from the unmet need. And if we assume that anyone working in this space has good product market fit, and they are addressing an important unmet need in terms of scaling, is first of all being prepared that it's a marathon, not a sprint, and then appreciating the differences across different levels, whether it's technical levels, clinical levels, commercial levels, between the different healthcare systems anyone is addressing. Because yes, especially to give you the example of stroke, the pathway is very similar across Europe and in the US. In the US, the American Heart Association now have their guidelines for all hospitals to be using stroke AI as routine care, but commercializing and clinically adopting a solution within a US healthcare system and even between different states is very different as doing something similar within the NHS in the UK, in Spain, in Italy, in Hungary. So appreciating the common themes and creating, if you like, a platform, which is a buzzword that has many different meanings nowadays, but also being prepared and investing even the local resources to understand the specific of each healthcare system someone is addressing.
Yeah. Thank you for that. So, Michalis, this seems like a really exciting time for Brainomix. What's next? What does the future hold for you and your team?
So absolutely, it's an exciting time, and we are at an inflection point because, as I mentioned, we have established very solidly our presence in Europe, where we have a very strong foundation. We are now focusing a lot in our US expansion in stroke, and what at the same time, the last few years, we have realized that our knowledge on what we built in stroke, and coming back to the discussion on what are the learnings from that, we came to the point where we appreciated that a lot of these learnings can be applied on other indications where the connecting thread is imaging and where imaging is defining how patients are managed, diagnosed, and treated. And we decided a few years ago that we would want to address another indication where there is a similar unmet need in stroke in terms of having a condition where imaging is central and knowing that patients are missing out from treatment, from life-saving treatments. And we identified lung fibrosis as that condition where we have already developed a solution. And this is a very exciting, again, opportunity and a very important clinical unmet need because in lung fibrosis, we have a condition like in stroke, very devastating. These patients that have this condition have a life expectancy of 3 to 5 years, which is worse than most cancers. And despite that short lifespan, it can take for those patients up to 2 years until they are diagnosed. So they might have symptoms, they might go and even have a chest CT scan in this case. But because it's very difficult to identify on a scan the features of fibrosis, of scarring in the lungs, and see whether this is getting worse with time. That's why it takes up to 2 years for these patients to be diagnosed. And after being diagnosed, getting access to antifibrotic treatment that slows down the progression of the scarring. So, as I mentioned, there are many parallels to stroke. Again, imaging is central. It's a different time scale, but again, the unmet need is paramount. And we have developed a solution which is already FDA cleared that can identify progression even up to 2 years earlier than how patients can currently be identified, progression of fibrosis, I mean. And again, what is very exciting is that we have a solution that currently there isn't a similar kind of technology in clinical practice. And the experience that we have in stroke enables us to take all the learnings we just discussed of how do you scale a solution, how do you make it clinically and technologically relevant to address a real unmet need. Importantly, again, it's worth noting that because of strong partnerships, for example, I mentioned to you, Boehringer Ingelheim BI is one of our strategic partners. They have important antifibrotic treatments in the space. So we both have knowledge of what the unmet need is, and we have the technologies in our case and treatments in BI's case that the two can work in synergy in order to ultimately improve patient management and patient outcomes.
Wow, that sounds fantastic, especially the fact that you have somewhat of a blueprint and now know how to scale that mountain, right?
Exactly.
Yeah. So, Michalis, first of all, I'd like to thank and acknowledge you for the time and input that you provided us with your knowledge here on MedTech Gurus today. If somebody wants to learn more, is there a website? Are you on LinkedIn? How do we learn more about you and your team?
There are different ways, and I would more than welcome anyone that wants to reach out and, if you like, continue the conversation or start a new conversation. And they can either go to our website, brainomix.com. They can reach out to me directly through LinkedIn. So I'm happy to get connected through different ways.
No, that's fantastic. So once again, thank you so much for your time and your expertise in being our guru today.
It was an absolute pleasure, Tom. Thank you very much.
Thank you. Thank you for listening to MedTech Gurus. I am Sylvester Harris, your MC. If you want to learn more about Tom and his consulting services, you can go to www.pctmedical.com or email Tom at tom@pctmedical.com. Now, I can be reached at Sylvester Harris, that's SylvesterHarris 5048@gmail.com, and I'd be pleased to discuss any voiceover work that you may want for your company or broadcast. Hey, thanks so much for listening, and catch us on the next episode of MedTech Gurus.